Greetings once again, everybody. Time for another lecture. Hope you're well. We're going to start off with depressive disorders today. And this will be around 15 minutes. And we're going to consider two. We're going to consider major depressive disorder and dysthymic disorder. Okay? So there's a video listed in your PowerPoint, and it's about 2.5 minutes of a young woman, which looks to be about 21, 22, who has major depressive disorder, I think. Seems to be. There are certain ways that we can't know for sure, but she's going to describe what depression is like for her. And I want you to watch that, okay? So let's start off with major depressive disorder. In the DSM-5, you have to have 5 of 9 symptoms for at least 2 weeks. Now, this is interesting, 2 weeks, because you may recall that many of the disorders we've looked at require 6 months of symptoms to be present in order to begin to diagnose someone with a particular condition. But in this case, it's 2 weeks. 2 weeks from normal functioning. And at least one of the 5 symptoms has to be a depressed mood or a loss of pleasure, which you may recall me labeling as anhedonia, A-N-H-E-D-O-N-I-A. So there's a depressed mood for much of the day, almost every day, in which the person feels sad or depressed, or, empty, hopeless, helpless in some ways. Marked diminished interest or pleasure in most activities. That's the anhedonia. Unintentional weight loss or weight gain. The idea here is unintentional, yes. Insomnia. Can't get to sleep, stay asleep, and either waking up repeatedly or getting up very early in the morning. In some ways, that can signal to you that the person is actually having a very significant depression when they get up around 4 in the morning or so and can't get back to sleep. Sometimes that's related to a very significant depression. Or hypersomnia. Some people sleep all the time. Okay. And then we have what's called psychomotor agitation, or what's more common, psychomotor retardation, where they can't move at all. Sometimes the person gets agitated, at least for different periods of time, but most of the time you see a psychomotor reduction in activity. They're slow to move, slow to react. That's psychomotor retardation. Then fatigue or loss of energy, most of the time. Feelings of worthlessness, pathological guilt. They feel like they've done things that an over guilt response for things, maybe even things they haven't even done. They imagine they should have done things and feel guilty that they didn't do them. Can't think, concentrate, indecisive. And then suicidal ideation. They think about it. They'd rather not be there. They may or may not have a specific plan. If they have a specific plan, it's more serious. And we actually have a protocol for someone who has any suicidal ideation that gives us an idea of whether we need to hospitalize them or not. So if it's a significant ideation along several different variables, then we would want to make sure they had someone with them and remove all means of hurting themselves or possibly hospitalizing them. And again, like all disorders, this involves distress or impairment. And so a way to remember all these symptoms is something that med students learn. It's called SIGE-CAPS. S-I-G-E CAPS. SIGE-CAPS. 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 Say it over and over. SIGE-CAPS. Sleep, interest, guilt, energy loss, concentration, appetite, psychomotor retardation or agitation, and suicidal ideation. That's SIGE-CAPS. Easy way to remember it for testing purposes, yes? By the way, if you decide to go, you want to go to grad school eventually, remember SIGE-CAPS. You'll remember I told you this. SIGE-CAPS, SIGE-CAPS. Okay. In younger children, I want you to know that symptoms of depression may include mostly just emotional stuff that they're not completely aware of. Sadness, irritability, which is more common in children, worries. In adolescence, it may be anxiety, anger, withdrawal, social withdrawal, changes in thinking and sleep in both adolescents and adults. So in kids, you might see disruptions in school, behavioral problems erupting. In teens, they may stop doing work. Their grades may start to suffer, social withdrawal, those kinds of things. In older adults, there is still a stigma about seeking help, so they may not seek help. It may be misdiagnosed. Some of the issues like appetite changes and sleep problems and those sorts of things, loss of interest in sex. Sometimes those are associated with, in the minds of clinicians, they're not thinking fully, with just being old. And of course, none of that's typically necessarily old. That may very well may be depression. So we have to be careful about that. Older adults may actually not want to get out a lot. They may have a lot of pain when they move from arthritis and so on, or they have other medical concerns, and they feel safer when they're home. And so that might or might not be something you'd know. You'd have to investigate that. Okay, you want to know what that's about. It may be a practical reason for not leaving home, or a preference, as opposed to a symptom of depression. So we want to know. Older men, particularly if they are alone, if they don't have a partner, they live alone, are a particular risk for depression. Okay? As with all disorders, you can have mild, moderate, severe. You can even have such a severe depression in this form of depression, major depressive disorder, that you actually are psychotic. You can be so depressed you can barely move. There are lots and lots of what we call specifiers. We've talked about these before. There are lots of them for major depressive disorder. You can be so depressed you're catatonic, you can't move. You had what's called waxy flexibility. We'll talk about that when we consider schizophrenia next time. But overall, major depressive disorder is more common in women. Yep. And episodes for anyone, male or female, typically last between 6 and 9 months. Okay? And we, in this state of ours, along through the South, are at some of the highest risks for, in other words, we have the highest prevalences for major depressive disorder. And there are a number of reasons why. I'll let you think about that. Now, there are also medical problems. One of those is diabetes, which is more common in the South. So I've given you one hint. Lupus, rheumatoid arthritis, cardiac problems, endocrinological problems, other than diabetes, gastrointestinal problems, hematologic problems, nutritional deficiencies like vitamin B12 and iron, infectious encephalitis, hepatitis, influenza, mononucleosis, pneumonia, tuberculosis. The list goes on and on and on. And really weird ones too. Neurological ones, subdural hematomas, multiple sclerosis, Parkinson's disease, epilepsy, psoriasis, renal transplants, heart transplants. In fact, for transplants of any kind, particularly cardiac heart transplants and renal transplants, and to a lesser degree liver transplants, you can kind of hang your hat on looking carefully to see whether that person's going to get depressed, because they have a much higher risk for that. Yeah, people with middle-aged men or older men with heart transplants often get depressed. It's an existential crisis in a sense, isn't it? Drug use, beta blockers, barbiturates, amphetamines, corticosteroids, high blood pressure medications, oral contraceptives. The list goes on and on. Now, the risks go up the more episodes you've had. So if you have one episode, you have a 50-50 chance of having another one. If you have 3 episodes, you have an 80% chance of getting another one. The average number of episodes, though, across a lifetime is about 4. We want people to take all their medications and take them as directed. Okay. Along with major depressive disorder, we want to look at what's beneath that. So if somebody comes to you and says, I have major depressive disorder, which came first and what else is there? Obsessive compulsive disorder, substance use problems, panic attacks, panic disorder, other anxiety disorders, borderline bipolar disorder, bulimia, anorexia. What else is there? And which came first? And that's going to give you an idea of what to treat first. And you sure don't want to miss stuff that's underneath the surface, do you? No. If you don't treat what's underneath the surface that may have erupted into, that gave rise to the vulnerability of being depressed and now the person has depression, then you're never going to fix the depression if you don't go back to the original source eventually. All right. So there are genetic vulnerabilities. There are cognitive elements that give you vulnerability in the way you think negatively, for example. There is a connection to having poor social skills and depression. There's all sorts of things that contribute to this. The next disorder I want to talk about is dysthymic disorder. We actually now call it something a little different. It was once called dysthymia. It's now really called persistent depressive disorder. That's a good name because it's something that goes on and on. We actually see it for a minimum of 2 years, sometimes called a junior grade depression. The symptoms are about the same as major depressive disorder. I don't know why I'm doing that, but I am. But they're less severe, okay? And many clinicians, including me, think about this disorder being more connected to personality traits and factors, such as pessimism or other personality disorders, like dependent personality disorder, for example. Now, you can have both. You can have major depressive disorder and persistent depressive disorder. That's sometimes called double depression. That's a rough one. In children and adolescents, you have to have the symptoms for at least 1 year. In adults, it's required that you have a 2-year period. Okay. Now, this disorder is much less common. It's probably 1% on average of the population, as opposed to more like somewhere between 8 and 15% for major depressive disorder. 50% is a little high. We don't really know exactly. All surveys are wrong. But if you're looking at what that looks like, it's uniform. If you look at a map, which I included in your PowerPoint of this disorder, then you'll see it doesn't stand out in any particular area. And that's because the percentage is relatively low. You're less likely to pick up hot spots of this. And it may be, if it is related to personality, going to disperse the statistics more evenly. Okay, now a subcategory disorder, which I want to go into just briefly before we say goodbye, is a subcategory of major depressive disorder called seasonal affective disorder. It's actually not called that anymore. It was once called that, also labeled acronymically as SAD, S-A-D, seasonal affective disorder. It's now subsumed as a specifier under a separate case under major depressive disorder. And it refers to the idea that the less sunshine you get, which would be in the winter months, the more likely you are to have depressive symptoms. And this is a real thing. If you look at the maps I show you in your PowerPoint, you'll see that the higher the latitude that you live at, for the northern states on into near the Arctic Circle, there's a greater emphasis, a greater prevalence of seasonal affective responses. Okay, so one of the results of that is that they offer full spectrum lighting treatments for that as well as antidepressants.